So we're doing well with cameras on this morning.
Right, good, good, good.
That
Give
was
a
my,
wave, everybody who's in your office, in your work office. Small numbers, small numbers. Give a wave if you're in your bedroom. Couple of people in their bedroom. Okay. Give a wave if you're at the kitchen table. Yep, there's kitchen tables there. Give a wave if you have a proper office at home, proper desk. Hey. Okay. So I think we're just on time now, so I think we might just start dead on time. So first of all, you're all very welcome to this PEIN seminar. Just in a couple of minutes, we're going to hear a little bit about PEIN, and then move into the webinar. What if people would make use of the chat function during the webinar and just put in any comments, any feedback, any thoughts, any questions, and we'll try and capture those as we go, and then bring them into the panel discussion at the end. So that's going to be really helpful. We're going to have a little break in the middle for people to have a comfort break, walk down to the end of the garden and back again, unless you are out in the country and you've got a huge, Alice can't do that because she's got to go up the top of that hill behind her. Just we'll have a little break for that. And we're going to use Mentimeter, and when we get to use Mentimeter, Rebecca will explain what Mentimeter is and how it works, but it's very easy. Just have your phone to hand, because you're going to need to use your phone on 4 different occasions during the event. And in the session after the break, we are having a number of presentations on resources for parents and practitioners. And at the moment, we have presentations from the HSE Nurture programme, from Young Knocknahini, and from Preparing for Life. And if anybody else has something that they want to say, I've got a resource that I use all the time and I really recommend it, just stick that information into the chat room, and we'll just invite you to just do literally a 1-minute piece on it to tell us about it at 11:10. Okay, so I'm just going to formally declare this webinar a no COVID zone. I'm so tired that every time we have conversations, it has to have COVID in it. So infant mental health was really important before COVID ever happened. It's really important during COVID, and will be really important when COVID is long gone. So unless you really need to talk about COVID, let's have a COVID-free environment for the next 2 hours. Okay, so I'm going to invite Lindsay now to just say a few words about PEIN. For those of you who've heard her words before, please listen all the more carefully and repeat them back to everybody you know in order to get new members to join PEIN.
Yeah, so sorry about this now to all who's heard it already, but there are a lot of non-members joining us this morning, so I just want to give you a quick overview of PEIN, but also just to say, yeah, you're very welcome to this morning's session. You'll have gotten an email, so you understand you've joined and you're automatically muted. So we just want everyone to keep their microphones muted throughout, unless you're speaking, unless you're the speaker. It just makes it a little bit more easy to follow, I suppose, and minimizes distractions. Francis said as well, just use the chat function throughout. So we really want to encourage engagement. We have found our webinars to date have been really engaging and very positive, kind of light events. And so use the chat function throughout. And there will be an opportunity at the 11:10 session to unmute and to speak about any examples that you have of best practice in your day-to-day practice. So I'm going to pass you over to Rebecca soon, and she will go through Mentimeter just for any of you that haven't used that tool before. Again, it's a very easy to use tool. It's another way for you to engage with this morning's session. And it's just, Rebecca goes through some of the technicalities, but it's very easy to use. You don't have to use it either, but we do encourage people to engage throughout. I suppose one of the things that we found in PEIN is that any of our networking sessions, any of our launches, our AGMs, anything like that, members always talk about the engagement that they have with one another and their colleagues, and that's one of the strongest features of our events. And so we don't want to lose that despite being online now. So PEIN This is my PEIN spiel. PEIN stands for Prevention and Early Intervention Network, and PEIN is a national network of prevention and early intervention services and supports in Ireland. So what we do is we bring together evidence-based practice, advocacy and research organisations seeking to improve the outcomes for children, young people and families. And our aim is to promote quality in prevention and early intervention practice and policy. We've been in existence for about 10 years, starting as an informal network of the ABC projects, many of who are here today. But we now have members across a range of sectors. So we have members from the general community and voluntary sector, the education sector, health, the early years and the housing sector. But within all of those sectors, we continue to keep a very strong focus on prevention and early intervention just within that context. So for example, we would have TUSLA, Bernardo's, as I mentioned, the ABCs, we have TROR, we have Alcohol Action Ireland, our members now. We have the Family Resource Centres, the National Federation and individual family resource centres, as well as Children's Rights Alliance and Catherine Howard. So I suppose that listing is just to give you a sense of our reach kind of nationally, our reach then to smaller, more on the ground services. And as we've developed, I suppose, and our network has grown, we've increasingly taken on that advocacy and policy role. So again, many of you, especially our members, would be aware of some of the things that we've worked on, but we would have been involved in the prevention and early intervention unit in the Department of Expenditure, in establishing that unit. We also would have been involved in advocating for the inclusion of prevention and early intervention in the national policy framework, Better Outcomes, Brighter Futures, as well as the inclusion of prevention in the founding legislation for TUSLA. And I suppose prevention is something that we try to focus on as well. It can be harder for our policymakers to take a preventative vision in terms of the work and priorities. There is still a lot of work to do to achieve all of what prevention and early intervention has to offer. And I suppose what we are doing now in our network is we're building our network and we're growing that network. And we're delighted that this year we have a lot of new members who we haven't had before, as well as our existing members who've been with us for a number of years. And so that gives us a real range of experience and expertise that we can really bring to the fore in that national context. You will have seen the PEIN website link on some of your emails as well, but I'd encourage you onto the website. You will see different videos for our members. You will see videos and recordings of our webinars. We will always try to host our webinars online afterwards, so that people who can't make the event itself can view it and can experience and I suppose benefit from the other members sharing their expertise, as well as different speakers that we'd have on the day. So do take a look at our website, follow us on Twitter. All of those spaces will give you a real sense of what's happening in PEIN and what's happening in PEIN right now and how you can get involved, because for us as a network, we are as strong as our members' involvement is. So any ideas, any challenges you're experiencing, any experiences you're having at all on the ground, I suppose, make us aware of it. If we can help at all in terms of working towards advocacy around any of those issues, we will do so. And we do that all through our membership. We do that all through working groups. And so you'll be involved throughout that process. So yeah, like I say, our work plan comes from our members, and our members are involved in all aspects of PEIN's work. I'm going to leave it there. Hopefully I didn't bore the people who already heard this before or who are already members of PEIN, but I'm going to send you over to Rebecca now, and Rebecca Burney is going to just outline Mentimeter, just for those of you who need a reminder or who haven't used it before. So Rebecca, if you want to go ahead. And actually, just before I do that, I want to remind everybody that I did say in the email, this morning's session is being recorded. So we're going to press record now, and this recording will be made available on the website. Do let me know if you've got any issue with your image in that regard or anything like that. It's just to make you aware of it. Thank you.
Hi everyone, how are you? Thanks, Lindsay. Yeah, so my name's Rebecca, and just to give everyone a heads up that if they have any issues with the technical sides of things, you can send me a little private message in the chat box and I'll try to help as best I can. But basically, I'm going to be sharing our Mentimeter this morning. So it's very, very simple. So I'd like you to go to www.menti.com. You can do it on your phone or another tab on your browser, and enter the code 843737710. And yeah, so we're just trying to get a little bit of a grasp, open up the morning. If anyone has any issues, let me know. But we'd like you to answer if you're a parent, an early years practitioner, healthcare professional, social care practitioner, policymaker, academic, researcher, or if you have another title, we'd love you to say it in the chat box. There you go, Francis. You have your
Okay, we got a few others. So please, the others, please tell us who you are and what you are in the chat box. Social care practitioners are coming up high there. A couple of academics and some early year and health year practitioners. So let's see, we've probably got about a quarter of you coming in at this stage. So if everybody else has an opportunity to see, let's just see what the chat box has to say about the other people. So we've got an assistant psychologist, an infant mental health coordinator, you should be speaking, ABC manager, and theatre making work for the early years audiences, the amazing Anna, and early years practitioners coming up high. Okay, so this gives our speakers also just a sense of who we are and where we're coming from, just in terms of the audience and who we might want to look at, you know. FRC manager popping up there. And are the early years practitioners going to beat the others or not? Okay, so we've got a good spread there. We've got a good spread.
Yeah.
Okay, do you want to move on to the next? We've 3 quick Mentimeters now, just getting a sense of where you're coming from, and then that'll set the tone for the session. So the next Mentimeter, over to you, Rebecca.
Yeah, you shouldn't have to stick in a different code. It's the same code. It should just be the next question. So how much do you already know about infant mental health? Nothing, a little bit, quite a bit, or lots?
Okay, so we're very much in the middle ground. Oh, the lots people are they're slower with their phones, but they know they're infant mental health. Okay, so we've quite a number of people who know either nothing or just a little bit. So again, for our speakers, just to note that, not to assume too much. And at the same time, we've got a good number of people who know quite a lot, and a few experts in the field. Okay, that gives us a good feel there of the sort of the spread of knowledge we've got. And then the final Mentimeter for now.
Yeah, sorry, have to do them all separately. So give me 2 seconds. And I'll get Menti 3. So this one's slightly different. It's a bit more of we need your input a bit more. So we'd like you, this is a different code, unfortunately, sorry. So we'd go to menti.com and enter the code 7055362, and we'd like to know, what do you hope to learn from this webinar? And we'd like to know in like keywords or short phrases, and everything's going to appear up in like a word cloud. So that would be great. Thanks.
Okay, so this again is just to give us a sense of what we might come back to, particularly in the closing discussion, if there's particular themes coming up that would be helpful for us to just take note of at this stage and make sure that we cover before the session is over. Knowledge, I think we can provide that, I hope. More tools for my toolkit. Okay, yeah. Best practice, awareness, informed practice, connectivity, aspirations, funding. I don't think we're going to offer funding, but we'll certainly can have that discussion about what's needed for it to happen, and we can talk about that a bit more. Wow, there's loads coming up here. Supporting new family solutions, improving practice, more awareness, connectivity, practice ideas. So best practice, knowledge, and awareness are the key things that are coming up in the middle there. And information. Okay, that gives us a really good flavor of why people are here and what they're hoping to get from the session. Okay, with that, I'm just going to close that down. Thanks very much, Rebecca, for your support on that. And I suppose just to say, I mean, infant mental health is a phrase that we've started using I don't know, probably in the last 10 years, something like that, where we've been using it a lot. You'll gather from looking at me that I did my training a few years before that. And when I was training, we would have used phrases like bonding and attachment. And yet that's now been captured into the broader field of infant mental health. And I think there's some debate within the field even about the use of the phrase, which we might touch back on later on as to whether it is a phrase that causes difficulties for some people and other people find really helpful and really important. I suppose PEIN focusing on prevention and early intervention, infant mental health goes right across the spectrum from very high-end and intensive therapeutic inputs to children with severe issues, right through to universal supports for children and families. So we'll certainly reference the full range, but the focus of today's work is really going to be on the prevention, early intervention end of that spectrum. Okay, so with that, we're going to have an opportunity, as I say, for questions and participation later on in the session. But do use the chat room as we go. I'm now going to share my screen, and I am going to cross my fingers and hope that the this all works for us. So just a short 2-minute video from the Harvard Center for the Developing Child.
Lasting impact on the architecture of the developing brain. A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later. Through this process, neurons form strong circuits and connections for emotions, motor skills, behavioral control, logic, language, and memory during the early critical period of development. With repeated use, these circuits become more efficient and connect to other areas of the brain more rapidly. While they originate in specific areas of the brain, the circuits are interconnected. You can't have one type of skill without the others to support it. Like building a house, everything is connected, and what comes first forms a foundation for all that comes later.
Okay, so a little bit of science to kick us off, and just, really stressing that not only is infant mental health something we should be doing socially in terms of the development of our children, but this is backed up by absolutely powerful medical evidence. And on the resource sheet, there will be a link to the Center for the Developing Child, so you can look at other resources that they have. It would be great to have some of those resources with Irish accents on it as well. So at this stage, I'm going to hand over to the first of our speakers, and I have told our speakers that I'm going to be very strict on time because we can get into Zoom fatigue if we don't. So we're going to try and keep on to the time frame as tightly as we can. And our first speaker giving an overview of infant mental health and its evidence base, and particularly its growth in Ireland, is Audrey Lonergan, who is principal psychologist with the HSE and also an executive member of the Irish Association for Infant Mental Health. So over to you, Audrey.
Okay, thanks very much, Francis. Can you hear me okay?
Loud and clear.
Okay, great, thanks. I'm just going to try and hide the presenter view. Okay, so thanks very much, Francis, for inviting me to come to speak to everybody this morning on the topic of infant mental health. So I'm a psychologist and infant mental health specialist working here in Clonmel for over 10 years now with two colleagues, Fionnuala O'Shea, who's going to speak to you later on, and Rosario Donnan-Connaughton in the psychology department. And we've been working for a good while now on trying to, I suppose, build an infant mental health community. We've worked with Nurture around the universal promotion and prevention strategies. And then we also provide an infant mental health individual one-to-one service here. So it's with great pleasure that I was asked to come to talk to you this morning and to share some of what we know. I suppose just looking from the Mentimeter there's lots of varying levels of exposure, I suppose, to infant mental health. And for those with prior knowledge, I hope that the morning will be a chance for you to reconnect with infant mental health and to maybe network with colleagues and like-minded people. And then for those maybe that don't have as much exposure, that we succeed in giving you some flavour of infant mental health and what it's all about. Again, we are slightly limited by time though, so hopefully we'll be able to meet some of your expectations. So I'm just going to talk to you about the concept of infant mental health, just a really brief introduction to the concept. Really briefly, I suppose, mention the evidence base, as Francis said, and as the video there speaks to. There's really a growing empirical base to indicate that the early years there's a critical window, I suppose, for us to be able to intervene at that stage. But I guess I'm speaking to the converted here this morning anyway in that regard. And then to just give you some brief updates, I suppose, on the development of infant mental health in Ireland. I suppose the other hat I'm wearing here this morning is since Monday night, I've taken over as president of the Irish Association for Infant Mental Health. So I'll be able to tell you a little bit about that as well. So firstly, what is infant mental health? Well, we can say what it isn't, first of all. As this picture shows, the psychiatrist saying, I wish I'd started therapy at your age. Infant mental health most definitely isn't about mental illness in the baby, or isn't about providing therapy to the baby. As Francis referenced there is a lot of debate about the topic, about the term infant mental health, and it isn't one we'd necessarily always use with families, but we can come back to that later. So infant mental health is about paying attention to the social and emotional development of the baby. It's about paying attention to those very early first relationships. And as the video referenced, we know from decades of research now that those early relationships really form the foundation for all development that comes after. So a formal definition is infant mental health is a field which is dedicated to understanding and treating children from pre-birth to 3 within the context of family, caregiving and community relationships. So that speaks to, I suppose, the breadth of different clinicians and practitioners and interested individuals, I suppose, within the field. So it refers to people in early years education, it refers to mental health practitioners, social workers, pediatricians, community providers. So it crosses the full gamut, I suppose. So really, anybody that comes in contact with a baby has the potential to be able to support that baby's mental health. And there's a worldwide group of people, I suppose, who are dedicated to promoting the social and emotional well-being of infants. And that's through the World Association for Infant Mental Health. And we're very lucky in Ireland here to have an affiliate of the World Association, which is the Irish Association for Infant Mental Health. So infant mental health is a field, but it is also focused on the child and three big interrelated tasks of development. So infant mental health focuses on the infant and toddler's capacity to form close and secure relationships. So that's as the basis for everything else, that attachment with the primary caregiver or parent. That then forms the scaffolding for the baby to be able to experience and regulate and express emotions. And as we know, emotional regulation is a key early life skill that's developed, I suppose, and that's necessary for to be mentally healthy. And with those two areas of development built upon that, then is the ability for the young child to be able to go and explore the environment and learn. And it's only with the previous development being on track that they're able to do that. And then wrapped around all of that, wrapped around the baby is the family, the community, and the cultural context. There's a big emphasis, I suppose, in infant mental health on the cultural context of the young child. And that definition comes from the 0 to 3 Infant Mental Health Task Force. So infant mental health, to sum it up, really, it's all about relationships. It takes a village to raise a child, and I suppose that's what we're doing here. Even this morning, I suppose, is building an awareness, coming together as practitioners who are interested in this area to see what we can do to support those early years. And infant mental health is as much about the relationship that we have as practitioners with the families, as well as so if we can support the parents, then the parents are in a better position to support the baby. So it helps sometimes to think about like what's different about infant mental health, and we would I suppose often go back to the origins of infant mental health to explain that, and just really to just briefly reference the origins of infant mental health go back to Selma Freyberg, who was a child psychoanalyst and a social worker as well. And she coined the term infant mental health and kitchen psychotherapy. And really what in her seminal article, Ghosts in the Nursery, she asked some key questions that maybe hadn't been asked up to them. In the article in Ghosts in the Nursery, she talks about a depressed mum who turned up at the social work offices and wanted to give her child up for adoption. And this mum was seen as an abandoning mother. And her and her team at that stage were setting up an infant parent unit. And as they discussed that case around the team meeting, one practitioner asked, "What about the baby?" And that was really a key moment, what she describes as the first time that they had considered, you know, how is this baby experiencing this mother's mood difficulties. And I suppose that was the first time that they put in an intervention that was focused not just on the baby or not just on the mother, but on the relationship between the two. And that's really the key for infant mental health, is that it's not either the baby or the mother, that we support the baby through supporting that very first relationship. And when I say mother, that could be father, it could be grandmother, it could be foster parent, adoptive parent, whoever is the main caregiver. So in that article, and for anyone without any prior knowledge, I'd really recommend that. Like, it is a bit dense and heavy as an article, but it really is a great introduction to the concept of infant mental health. And since then, I suppose the research has really confirmed what they knew in those early days in the 1970s and 80s. So from Selma Freyberg's work then in developing a model of infant mental health, I just said I'd pull out some of the key principles, I suppose, that there are a good few of them, and these are ones that maybe just speak to me in my practice. So one of the main principles is that it brings the baby into the primary focus. So the baby can speak to us, I suppose, even though they don't yet have language. And Kevin Nugent and with the NBO would very much, he was here last year training us, very much spoke about that, that the baby can speak to us, not verbally, but in their behavior and how they are. And it's up to us to listen, to hear their story. So that's a key principle, that the baby can tell us lots if we're prepared to listen. Honor the expertise of the parent and their past experience, I suppose. And again, a key tenet is that we nurture as we have been nurtured ourselves. So if a parent isn't being as sensitive as we would like with the baby, infant mental health helps us to think about what might that mum or dad or whoever have experienced that is blocking them from being able to be sensitive. And in that Ghosts in the Nursery article, they very much depict how a parent must feel nurtured in order to be able to nurture. In that article, she asks, what is it about this mother that she's unable to hear her baby's cries? And she documents how the therapeutic relationship had to be built with that parent. And she had to tell her story and grieve her losses and her trauma, so that she was in a position to be able to hear her baby's distress and her baby's cries. Infant mental health honours the expertise of the parent. Again, that's not unique to infant mental health, but it is a very strong tenet of it as well. As I said, it attends to the developing relationship between the parent, or between the baby and the caretaker, and the baby proceeds through overlapping stages of development. And I think the brain video very much spoke about that each stage builds upon the previous, and it's not that you can't make up for lost ground. You very much can, but I suppose it's a lot harder. And ideally, for optimum development, each stage the baby reaches they're able to reach on their development at each stage to be able to progress to the next. And finally, I suppose the hopefulness, that's a principle that I really like to hold on to, because I think, like in all my years, and it's probably too many years now for me to care to remember them all, but I don't think I've ever met a parent who hasn't hoped for the best for their children, and hasn't hoped that if they have had losses and traumas, that they hope for something different for their family. So the birth of a baby brings that potential for growth and development. And as Alicia Lieberman would say, if we don't have any positive memories, we can make new ones. So therein lies the hopefulness of infant mental health. I'm just wondering how I'm doing on time.
Audrey, I'm just going to flag that with you. If we could aim to finish in 5 minutes, that would be great.
Okay, perfect. I had some slides, and I'll email the slides on to yourself, Francis, and you can maybe distribute them, so I won't have time to go through that. But like there's some information if people are interested in reading further around the empirical support and the longitudinal data, and then the evidence from the neuroscience, I suppose, into why we need to intervene in these early years. And as Francis mentioned, infant mental health is a continuum of service, and there are programs being developed all the time, I suppose, and with evidence as to their effectiveness and efficacy. So at a universal level, examples might be the Solihull program or the NBO program, which can be rolled out universally. And then some examples of, from a preventative point of view, that could be group or individual work, that mellow bumps, floor time, third play, circle of security. And then the intervention for high risk, where those ghosts in the nursery have taken up residence, I suppose, and the parents' past, I suppose, is really getting in the way of the present relationship with the baby. They would be very high risk, I suppose, and would need onward referral for more intensive work. And underneath that, I suppose wrapped around all of that is the reflective practice and reflective supervision. And finally, sorry now, I'm just flying through this, just to tell you about the Irish Association for Infant Mental Health. We are very much growing our infant mental health community. We have almost 100 members now at the moment, and we're hopefully going to grow that membership number. We're involved, I don't want to mention that C word that Francis said we're not supposed to be mentioning, but normally every other year we would be providing training and masterclass training, but unfortunately this year we haven't been able, but hopefully next year we'll get that back up and running again. And membership network events. We were very lucky, I suppose, a year or two ago to be able to buy the infant mental health competency guidelines. So any training that we offer, or we can other organizations can purchase those competencies to make sure that their training is aligned along those competencies, and it speaks to the quality of the training. A major goal of ours is to build capacity within the executive committee and within the broader membership to be able to administer an endorsement program in Ireland. So if you're doing training, if you're working with young babies and families, that you could be endorsed for that work at various different levels. And speaking to the worldwide network of practitioners in infant mental health, we were delighted to have one of our executive committee members and past president, Catherine Maguire, was elected onto the WAME board. So that was a great achievement for us, and we're very proud of that. And then finally, I suppose to mention that we were lucky in succeeding in the bid to hold the World Association World Congress in Dublin in 2023. So that's going to be a great opportunity for us all, I suppose, involved in supporting families with young children, and to be able to showcase, I suppose, what's happening in Ireland, and also to be able to hear all the fantastic work that's happening around the world. So that's that. And if anyone is interested in joining, and we're always interested in opening up or increasing our membership, so we'd love to hear from you. And that's the email address there. And just finally, I know that on the Mentimeter there, a lot of people had said around knowledge and awareness. I've just put up some ideas of training opportunities that I'm aware of. There's a Baby in Mind course, Nurture e-learning. We've been, and Catherine Maguire and ourselves here in Tipperary have been involved in developing e-learning modules, and it's very much hoped and anticipated. If they're for public health, but it's very much anticipated that we'd like to be able to release that to as many people as possible. The master classes, as I was saying, hopefully next year they'll get back up and running. And the network groups, which Naomi and Fionnuala will speak to you about, having completed a masterclass, they really are a key holding, I suppose, our forum where that ongoing learning and reflective practice can take place. Warwick University have infant mental health online module, and the Bruce Perry series on YouTube was fantastic. And then the Anna Freud Centre in the UK, they run a really great online course as well that was in person but is now gone online. So that's it. And just wanted to finish off with a lovely quote from Terry Brazelton, who designed the NBO. And I think it speaks to what infant mental health is about. So every time you give a parent a sense of success or of empowerment, you're offering it to the baby indirectly. Because every time a parent looks at that baby and says, "Oh, you're so wonderful," that baby just bursts with feeling good about themselves. That's my presentation. Thanks very much for your attention.
Audrey, thank you so much for that input. Congratulations on your appointment as president of the Irish Association of Infant Mental Health. I know you and your colleagues were involved in organising an amazing seminar last May in Clonmel, a national symposium on infant mental health, with the Kevin Nugent from Mullingar, who works in the States and is one of the leading people internationally in this work, and very much one of our own. I think that's a great whistle-stop tour of where infant mental health is at in Ireland at the moment and where it's come from, and the work of the association. So we're going to very quickly move on to hear about some infant mental health in practice. And the next presentation is a joint presentation from Julianne Lyons in Young Ballymun and from Richard Duffy in the Rotunda Hospital, our busiest maternity hospital in Ireland, I think. I'm not sure which of you is going first, but I'm going to pass over to you now. And again, I'm going to keep you tight on time, folks. So away you go. It looks like Richard first.
Yeah, brilliant. Thank you very much, Francis, and thank you so much for having us here. I am one of the consultant psychiatrists who works in the specialist perinatal mental health service, which we now have across the country, which I think will do a huge amount for infant mental health. What I want to do today is actually, I don't have any slides, and I just want to tell a person's story and just highlight all the different points along the way where they could have had some contact or did have some contact with someone who was just helpful to them. And so I want to present just in the last few months a lady called Fiona. This isn't her real name, and she's actually probably a composite of 2 or 3 cases, just in case anyone feels uncomfortable that I'm giving lots of information. It's a few different people pulled together with some things changed. But she was admitted to my ward about 4 weeks postpartum. As a perinatal psychiatrist, I don't have a ward, but I also work in the mater where I do have some beds. And she was brought in on forms, which meant that people were seeking an involuntary admission for her. Both her partner and her GP had felt that she'd become unwell enough that she needed to be in a hospital. And she'd started to get some very unusual ideas about her baby, and would go through periods where she firmly believed her baby was dead, and then would kind of realize that wasn't the case, and then would have to kind of check on the baby, and not in the has my baby stopped breathing kind of sense, but in a psychotic sense. She was also very restless. She wasn't sleeping, and when I interviewed her, she was talking a mile a minute. She would jump from topic to topic. She complimented me on my shoes on multiple occasions, then would talk about the fact that her baby was dead. Then she would move on to all sorts of other topics and touch on them briefly and go on to the next one. And so I definitely thought she did need admission. And thankfully, she was willing to come in because I'd actually met her before and had a bit of a relationship with her. And so she, because she knew me from the last time she'd been unwell, she agreed to come into hospital and stayed in hospital. And this was very distressing for everyone. And we really felt under pressure to get her well quickly, because especially when she initially came in, she agreed, but we felt that there was safety issues with her being around her baby. And because the nursing staff on the ward didn't feel they had the expertise, while we were trying to facilitate that, we weren't in a position to do it right at the start. And thankfully, within days, she really settled and was in a position that she could, we were happy for her to visit with her baby. But unfortunately, then there was COVID, and our ward hadn't had a case of COVID, and her parents who had wanted to support her had come from the UK, and they hadn't isolated, and they were seeing the baby, and there was a lot of issues with that, and some elements in nursing management and amongst the clinical director were very reluctant to facilitate a visit with the baby due to COVID. And there was a lot of advocacy that was done by mental health nurses and by other consultants on the ward to facilitate this. And a lot of steps had to be taken to along even with hospital management, with ID, to facilitate, infectious disease, to facilitate this happening in a hospital setting. And it was brilliant to see a lot of people that were advocating for her to do this. And so we were able to facilitate some visiting. And within about a week, 10 days, we were actually able to get her a very quick discharge, much quicker than a lot of people would be, because of the intensive input and the supports that we were able to put around her. But even during her admission, she was able to work with a lactation nurse. That meant even though she was so unwell, she pumped the whole way through her admission. And when she returned home, started to breastfeed, which I thought was amazing. And then she was able to link with the specialist perinatal mental health team on discharge. There was a few things as well that I thought were really interesting. Just there was a lot of points where she linked with the obstetric service before her delivery that I thought it just highlights how many different people she saw. And so she had a very high risk of developing a postpartum psychosis, and that's what led to her admission, and because she'd had a previous psychotic illness. And she was about her mental health history, and she had very sincerely said, "No, I have no history." And we see that quite a bit, that people just conceptualize mental illness differently. And so she saw that her previous psychotic episode was a delirium. But we also see a lot of people with a postnatal depression, and they see it as a brief episode of baby blues. And when you take a history, it's like, nope, really severe postnatal depression. So it really highlights how important it is to see how people conceptualize their own mental illness, and to really strike that balance between getting somebody's story in their own terms, but also being able to think about it in terms of medical terms. And does this mean that this lady is at risk, and what supports could help mitigate that risk? But during her pregnancy, she saw her GP, she saw her midwife, she saw her obstetrician. But many women in her situation would also see clinical nutrition, would see social work, or would attend our service and see people within our service. And at all these different times, there are people who can identify that there may well be a risk to somebody who has a previous mental health history. I also think as well, there's a lot of when we step back and think about the contact that you previously had with psychiatry, there's a lot of learning there. And to be honest, that was my team. But there was a real piece of important education that we could have done years before she even conceived, to very clearly communicate what is her diagnosis, what are the risks that has, what are the preventative strategies that can be used. And we see that pregnancy, parenting, breastfeeding are constantly considered in an ad hoc or in a post hoc way. They're not thought about as normal parts of life, which is a real it's a real difficulty in the psychiatry services. So it's only after somebody becomes pregnant that we start thinking, do we need to rethink this person's medications? We often see people started on antidepressants, women of childbearing age started on antidepressants that they then may have to come off, or that they have to have a conversation with, should we come off? What's the risk benefit? When in the first place, they could have been started on an antidepressant that would be safe if in the future they would choose to become pregnant. There's a really nice piece of research a registrar did with myself called, her name is Emer McGuire, and it looked at inpatient policy for mental health wards that relate to pregnancy and breastfeeding. And we expected to find that they didn't consider it well. They really didn't consider it at all. And there wasn't even we wanted to make the point that policy about pregnancy and breastfeeding should not be exiled to its own specific policy. It needs to be integrated with all other policy. It just didn't even have its own policy. It was just nearly entirely omitted, bar 3 or 4 areas. And so I think it's so important that pregnancy, breastfeeding, parenting, fertility, sexual health, these aren't an afterthought in psychiatry, that we really work to integrate that within policy in psychiatry. And so just as a brief summary, like, yes, this lady Fiona, she is the extreme end, but it does highlight how an awareness of perinatal mental health can do so much to improve infant mental health. And that this awareness needs to be present the whole way through somebody's interaction with mental health services. And if I have 3 take homes, I suppose it's that it's that first idea that pregnancy, parenting, fertility, breastfeeding, these can't be afterthoughts. They need to be integrated within mental health policy and within mental health care. I suppose that so many people have a role. The second take home is so many people have a role in identifying the potential risk for perinatal mental health problems and consequently often for infant mental health problems. And where people do identify that, it's to there's such a need sometimes to elicit that risk in somebody's language. I think this lady really points out how some people often, when they're pregnant, try to maybe minimize their past mental health difficulty. When in reality, if we can get a good history, we can do a lot to prevent stuff. And then finally, just there are good services that are out there for perinatal mental health. The HSE has really invested in perinatal mental health services in the last few years, and so there are excellent services. If you just Google perinatal mental health HSE, we have lots of flyers that are excellent. There's a really good poster on 10 things around perinatal mental health. There's an app for healthcare professionals that you can all access, which is a huge amount of information on perinatal mental health, all available. If you just Google perinatal mental health HSE, you'll find it there. You can also find a lot of these resources on the Rotunda website. And then women who are pregnant or are in their first year postpartum now have access to perinatal mental health services, and they are across the country, located in 6 hubs, but every site has at least a mental health midwife. I think bar maybe 1 or 2, but we're trying to find them where they're not there now. So it's been greatly enhanced in the last few years, and I encourage you guys to link with the local perinatal mental health service. Thank you very much for your time. I'll hand over to Jean now.
Thanks very much, Richard. That was really great just to hear all about the preventative side, because I know, Francis, you are very keen for both prevention and early intervention to be addressed. So, yeah, just in terms of the, let me get my slides up here for myself. Yeah, just so Richard very well identified how it's so important for all of us, all the different professions that you spoke about, the GP and the obstetrician and the different people, to identify that cluster of symptoms, and also to get kind of collateral history from family members if needs be. So it's a bigger picture, and it can be missed if people aren't communicating with each other. And as you say, Richard, if the questions aren't asked. So, and then again, when it comes over to our side of things, once the baby is born, how important it is to get in there as early as possible. And we're really working hard, and it's great to forge links now with the Rotunda to get that in place. And it's not always possible. We know there's different waiting lists. We know, for example, primary care psychology, it's hard because there's sort of a rigid wait list criteria, and it's hard, even though a lot of people would love to get in there early, it's not possible. So it's lucky with us in our infant mental health team in Young Ballymun that we do get in there and see them. So what I'm going to do today is present a case, and it'll illustrate how, when professional work is informed by infant mental health values, the outcomes can be really positive. So this is a case about a referral. It was from a public health nurse at the moment. Our team is small enough, so our sole referral agents at the moment are from the public health nurses. So this was, again, like Richard, this is an anonymized case, sort of a composite case that a lot of you here tuning in will be familiar with. We call a young girl called Jane, and she's residing in homeless accommodation, and she was recently bereaved, and she has a 1-year-old daughter. So the concerns were around attachment, they were around kind of general parenting capacity, and sort of hygiene around the baby. So a mehel was convened, and it was just to try and sort of mobilize community supports. And I think the idea of a mehel is really good, but as a lot of you are probably familiar with, it's not always perceived by parents in that way, that they really are attending these meetings in an involuntary capacity, and very much outnumbered by professionals, often using professional jargon. So in this case, the professionals kind of surrounding this mother were the speech and language therapist, public health nurse, the creche, there was a homeless link worker, myself, and then obviously the Tusla medical coordinator. And I just noticed at the time before this mother arrived late, and there was a conversation had started about the case. And when it was only the professionals, and again, this probably rings a bell with people, there can be a tendency to slip into sort of judgmental language and criticism. So there was kind of talk about how, you know, mum never answers the phone, or she's already missed 2 developmental checkups, or she's not attending creche regularly, and, you know, we're keeping the place open for her. And then she, you know, she rarely smiles at the baby, or there's a poor affect. And I think this can be quite contagious. I think this sort of talk, and it just takes one person to step out of it and to take that more compassionate, empathic position, and to say something like, it must be hard, given, you know, what Audrey was talking about, the ghosts in the nursery, given mum's experience, it must be really hard for her to relate to this baby. And immediately when one person puts that type of thing into the conversation, it shifts. I don't know, I've certainly been at meetings where I might have been saying something judgmental thoughtlessly, and somebody else says something very kind and compassionate, and it almost jolts you and shames you a bit. But you do shift more into that thinking, yeah, this is difficult, and what might make it hard for the mother to get to creche every day, or what might make it hard for the relationship. So you move much more into this curiosity about the meaning, which is what infant mental health really is all about. So it's really important to keep this lens to the fore. And we were lucky enough with this case, because of the different professionals working on it, that they were informed by infant mental health. So, for example, the public health nurse working on the case, she had attended the infant mental health masterclass that young Ballymun had presented over 2 days. And she said she actually became quite moved at the masterclass in kind of seeing the perspective of this mother from a different light. And because of that, she was able to move in a different way with this mother. So, you know, if she hadn't been making her checkups, her developmental checkups, that she might go out to her and wonder about that, and help her understand the baby's development and the toddler at this stage development, in more of a developmental norm, but in a kind way. And the mother as well, you might often this would be familiar, looking for an assessment maybe to see whether the child was on the spectrum because of difficult behavior. And again, this public health nurse was able to, she respected the concerns and was able to do the initial screening, but was able to talk to the mother in a different way about what else might be going on for the baby and what might the meaning of the behavior be. So the speech and language therapist, again, imbued in infant mental health kind of way of thinking, because she attends our network meeting. So this is the meeting that comes monthly, and I know this will be spoken about later, but it addresses all sorts of infant mental health topics every month. So she was very well tuned into this mother, wondering what would be best meet the mother's needs at this particular time, because the Hannon program had been mooted, but this speech and language therapist was wondering, is that the best way to approach it? And maybe the Circle of Security parenting program might be indicated at this time, might be more appropriate, just to look at the relationship, and maybe Hannon could happen down the line. And sometimes there's pressure to put lots of services on to different families, to the same family, lots of different services and programs. And this speech and language therapist was able to think about that and go, actually, you know, we don't want to overload this mother, and maybe the timing of the Circle of Security would be better now. So then the creche again, the early years providers in the creche avail of reflective supervision, which again is provided by Young Ballymun. So it gives these creche workers it's a lot of difficult, there's a lot they're dealing with in the creche, and they have a space where they can think about what's going on for the babies, maybe what's going on for the parents who are arriving with the children, and whatever they're presenting with, they can bring this to reflective supervision, and also what the impact of the work is on them, so they get a space to step outside of the immediate rush of the work, to think about the meaning behind the behaviour. And because of this, they were able to support the mum and understand why it might be difficult for her to attend every day at creche. And they were, in that way, they'd held the creche space open. Also, when there was kind of
Julianne, just to aim for about five-minute wind up.
Okay, thank you. Great. The lice issue, they were able to deal with it with kindness and patience and compassion. And I proceeded with doing circular security, and the creche let they gave us a room to do the circular security program, and there was that lovely nurturing. They came in with tea and biscuits and a lovely feel for it. And then the DePaul link worker, the homeless link worker, we took the opportunity to provide a 2-hour kind of workshop on infant mental health to the homeless agencies, to Focus Ireland and DePaul. And again, then they come at meeting with the families with a different understanding, and then advocating for the families becomes different with that understanding. So it hasn't all been smooth sailing, particularly with COVID. Sorry to mention COVID, Francis. But now this mother trusts professionals. It took a long time for her to come on board, but I think because she senses that we care, she actually said to me, I'm going to take all the help I can get now. So that idea that every interaction is an intervention, and that's so important. And the perinatal period is so emotionally laden, as Richard said so clearly, that things that are said can be remembered. So negative things as well as positive things. And it's so important for us to get in there with encouragement and positivity. And different professionals, hold different expertise, and that, Audrey talked about, the relationships not only with the worker and the parent, but also with the workers with each other. So we can get support from each other. Like, I wouldn't have expertise in terms of anything psychiatric issues, but now that relationships have been built with Richard, I can pick up the phone and say, can you contain this? I'm worried about this presentation. And with his expertise, he can say, that's okay, that's within the norm. And then I can hold the other pieces. And likewise with SLT and with public health nurses. So just to say, there are the ghosts in the nursery that Audrey spoke about, but also angels in the nursery. And we can be those angels, and there's an opportunity here for us all. We hold that empathic, non-judgmental approach. I just want to bring up a slide. Do I have time, Francis?
Just a quick one, yeah.
Okay, quick slide. Just I just wanted to show the different language we can use. The language of professionals can be, we devised this collaboratively with the public health nurses, a new kind of referral form to help us,
Your
to help them talk.
Slide isn't showing.
Oh, is it not? Okay.
No.
Well, I'll just, maybe I'll talk it through then. So there might be a tick box like saying lack of sensitivity to the baby's cues. So instead of that, you can talk about the parent needs help to understand what the cues mean, or negative affect openly shown towards the child. But you can interpret that as parent needs support in being able to enjoy their baby. Lack of eye-to-eye contact could be seen as we need to help the parent understand how their baby loves to look into their face. Lack of knowledge of parenting and child development, you can flip that to say the parent would benefit from practical information about what's happening. So it's about shifting it from this kind of professional judgmental language to thinking about what does the parent need help with, and how can we word it in a way that professionals can have a conversation with the parents about it and make a referral that feels joined up and they feel part of and willing to engage in. Have I stuck to my time?
That's great. That's great, Julianne. I mean, just both Richard and Julianne, thank you very much. Richard, I don't know if you're still with us. We could see you gearing up to go out.
Still here.
Oh, you're still with us. We could see you gearing up to go out onto the wards. Obviously, just thank you both for those insights from two different, very different, but very interconnected perspectives. I think the conversation is going on in the chat room about just the value of, first of all, psychiatry recognizing and embracing early intervention and prevention and the importance of that. And I think you really made the case powerfully for that, Richard. and then Julie just meeting the parent where they're at, and that caring and framing things in a positive way and in a supportive way, rather than seeing the problem, seeing the need and seeing the strengths as well. I think those are really important messages there for us to pick up on. One of the things I'm thinking, and we'll come back to this at the end, is whether we might follow this introductory workshop up with a more skills focused workshop in the new year, if the demand is for that. So you might just think about that over the break. We're going to go to a 2-minute break now, and thanks to anybody who can't come back. We hit 63 at our highest number, but for those who can be with us, we're going to come back again in 10 minutes. So just stretch the legs, take a stroll down the garden, make a cup of coffee or whatever, and we'll see you back in 10 minutes and resume the conversation. Mind yourselves. Take care. Bye. Just hope we just find it's good in these events to just take a little bit of space for people to stretch and not get stiff backs and things like that, like Juliana is suffering from at the moment. The next session is really what I was calling a marketplace session, which is just an opportunity for members to just pitch about work that they're doing that they think is relevant to this. So hopefully these are kind of approaches and resources that would be available for people to use within their own work. And we have 3 people at the moment who've indicated a willingness to talk to us, and we'll just go to them in a moment. But just if you have a favorite resource, if you're aware of something you think should be shared with people, please email that to us and we'll add it to resource list that we'll send out with the slides to all attendees. So the first person going to invite to say a few words is Sorcha Ní McNahuna from the HSE. She is a communications manager for child health with the HSE. She joined the HSE with the support of the Nurture programme, and part of her work has been about the universal provision of information and supports to parents. And she's going to talk to us a little bit about some of the work that she's been doing, with a particular emphasis on embedding infant mental health messages for parents in pregnancy and in early childhood. So over to you, Sorcha, if you're there somewhere.
Hi everyone, thanks very much, Francis, for the introduction, and hello, thank you for allowing me to join here. And I can see a few familiar names and faces there in the crowd. So yeah, I'm just going to talk very briefly about the resources that were developed through the Nurture programme, namely the My Child Study website and also the My Pregnancy and My Child books. And just, I'm sure some of you would already be aware of them, but just to really briefly highlight how infant mental health messages have been embedded and developed in those resources. So these resources are aimed at parents, they're not for healthcare professionals. So I'm just going to show you a few quick examples, but before I start, this is just what the My Child 0 to 2 book looks like. It's given to every parent by their public health nurse in the first visit after the birth, so within 72 hours. So we did a lot of research with parents, so I'm not going to go into it today, but you know, that really informed how this book was developed, the topics that were in it, and it is quite a large book, but it really, as the feedback has been, that it's extremely valuable. Then there's also, before that happens, the My Pregnancy book, which is given out at the first booking appointment in the hospital by at around 12 weeks or so. So again, this was developed using the same process, the same input from parents, and also I'll be talking a little bit just about how infant mental health was, you know, woven through that. And there's also a 2 to 5 book, which I don't have in my home office at the moment, but hopefully I'll get back to the office at some point over the next few months and grab that. So I'm just going to do a very quick presentation, just as it's easier than hopping from one web page to another. So I'm just going to share my screen now. So hopefully this will work. It's always very nerve-wracking when you're on a call like this, and it's yeah, going a bit, asking me how many participants can share at the same time. Okay, right, sorry, apologies. Okay, I think we're almost there now. So I hope you can all see that. Maybe you could just, Francis, you could let me know if
Yeah, no, that's good. That's
great.
yeah, oh, that's there. Yeah, great.
So the resources I'm talking about are the mychild.ie website, and then the books. And if you haven't seen a hard copy of the book, you can find them at mychild.ie/books, and make sure to put in the www. Because for some reason with our short hyperlinks like that, they won't work unless you put in www. So I'm just going to talk first a bit about the website. So this is one of the articles that were developed with the input of infant mental health practitioners. So this is about preparing to become a parent, and it really, deals with the kind of changes and feelings that people might feel in a different range of those. And it's an article that, it's a multi-page guide, as you'll see. So there's actually 3 different parts to it. I'm just showing you the first page there, but it's really, I suppose, what I've learned from hearing practitioners talk. It's about adjusting to the psychological tasks of, parenthood and so on. So it's written, like all our content, very much plain English, easy to understand, short sentences, and trying to make the content really accessible with and easy to understand. So that's just one of the articles that might be of interest to some people. And again, you'll see at the top there, you can see that it sits within My Child Pregnancy and Pregnancy Advice. Sorry. Then we also have, content on the website about, your baby's mental health is what we've titled it. When we're titling articles on the website, we review different search terms and go with what the more common search terms are that people are actually typing when they're searching for articles into Google. So this article really is kind of laying out to the parent and the key kind of infant mental health messages, with advice on responding to cues, helping your child manage their feelings, and also some content as well on a parent's mental health, and also signposting to different other content on the HC website that's relevant to parents. So again, we worked with people. Some of the people actually involved are on this particular session with us now, Audrey Lonergan and others. And so yeah, it's again just a really good, I think, overview and really practical advice. Then within the development section of content as well, we have social, emotional, behavioral development. And again, there's been some input there into that content about how parents can help support this part of development. I suppose as well, like we also have, there's another content here, piece of content, Life with a Newborn Baby, which is trying to address, I suppose, that can be a very tough time for people. It's a big shock system to have a newborn baby, and it can be a very difficult time emotionally as well for people. So within advice we have about dealing with that, we also are signposting, as you see at the bottom, related topic back to the attachment of bonding with your baby. And I suppose that's a big part of what we're doing with the website, is that we're trying to signpost people to articles that they may not actually have been searching for originally, but are related content. And I'll just talk a little bit more about, I suppose, we're trying to embed infant mental health messages where possible, and maybe in places that people might not necessarily have sought it out when they were searching for something, but we want to make sure that we're kind of exposing people to those messages in the relevant articles that they're arriving on the website. That's just the article that was signposted to, again, another article developed by infant mental health practitioners. So attachment and bonding with your baby, again, really nice tips on explaining, the real central role of the parent in developing that attachment, and again, linking out to those other pieces about responding to cues and so on. And I suppose, as I mentioned just there, sometimes people might not be searching for infant mental health when they're Googling, or necessarily bonding with your baby. But with the books and the website, we try and embed messages about infant mental health. So here's the guide on the website to bathing your baby, which is full of things like bath temperature and how to hold your baby in the bath, and how often to bathe them and so on. But you'll see there as well, we have a message in there about bonding with your baby during bath time, just a little short messages saying this is a really nice everyday moment where you can enjoy some time with your baby and bond with them. Now I'm just going to my pregnancy book, just a sort of a screenshot from this book here. So we have infant mental health related messages sort of embedded throughout that book, often in kind of small blue boxes. So if you get to see the book or look through it, the PDF online, you'll see it. So again, just a little, there's a section here on responsive parenting and also sleep, and then just a little kind of quote mark from the baby at the bottom saying it's not possible to spoil me, and I know I can count on you. It helps me learn the skills I need to suit myself. So throughout the books, we've just tried to put little bits of advice and tips and messages throughout, rather than maybe having one standalone kind of chapter on infant mental health, because people might not they might just flick through that or maybe not prioritize reading that over other sections. So that's the approach we've taken there. And then in examples from the My Child 0 to 2 book, again, we have messages and tips again in these kind of blue boxes just dotted throughout the content where relevant. So here's a little piece about responsive parenting and the influence of a parent on that and how they listen and respond to their child. And again, there's other content within those books on cues and so on. So here's a little bit here about, again, from the same 0 to 2 book on communication, and that little blue box there, again, just saying, you're your baby's best toy. You're the most important person in your baby's life, and how much your baby enjoys looking at your face and hearing your voice. So again, just another example of how some of those infant mental health messages have been sort of embedded throughout the content. And that's really just, because I know I don't have much time, that's just a really whistle-stop tour of where infant mental health has been woven through those resources for parents.
Sorcha, thank you very much for that whistle-stop tour. I mean, I think the key question was about not having, here's all the infant mental health information over here, here's all the infant physical health information over here. It's looking at the whole child and supporting the development of the whole child. And having developed the materials, Sorcha then went on to have her first pregnancy. So the reason she doesn't have the full version of the 0 to 2 book at home is because Fiach hasn't reached 2 yet.
That's
so
true,
listen.
yes.
Thanks for that, Sorcha. We're going to move on very quickly then to Catherine from Young Knocknaheeny, who I think is going to talk about the version of the wheel that they've been using. And I know the HSE were giving consideration to the use of the wheel as part of the work package. So it'll be interesting just to see. Hi, Catherine.
Hi, Francis. Hi, everyone. Yeah, Francis just asked me to share some of the resources that we use in Young Knocknaheeny, and I suppose if you can hear me, my speaker is coming in and out. But I suppose we've developed an IMH community here in Knocknaheeny, like Tipperary and Young Ballymun, perhaps, and we have direct services and capacity building and training and reflective practice and things. But obviously, we're confined by our geography. So some of the things I thought might be useful is just like I just concur the My Child's resources are really excellent, and we use those all of the time as well in our practice. And also, if you go onto our YouTube channel, there's all of our team have kind of, I suppose, use those kind of key messages around infant mental health to incorporate messages into everyday moments. And they were done in context of the C word, COVID, but they're useful, universal messages. And it just made me think about those, Francis, that I hadn't thought of previously. The wheels that you're talking about, which I know a lot of people here already are familiar with. So for those that don't, I don't know if you can see these are from both 0 to 3, which again have enormous amounts of resources, which are easily accessible, I think, for everybody. These baby wheels, this one is behaviour has meaning. So you look at the issue and you just use the wheel to slide it round, that might give you kind of some key universal messages that might help to explain to practitioners and to parents what might be happening, and to give that behaviour some meaning that you can respond to then, rather than seeing it as a kind of a challenge, but maybe as an opportunity to respond to babies and young children. And this one here is the baby stages, social emotional development over the first 3 years of life. So you just move it around and you see different kind of key messages that we universally we can all use, whether we're a parent or a practitioner. So that's kind of helpful too. And it's 0 to 3, and the Michigan Association have these wheels. So they're useful as well. The other thing. Francis.
Catherine, if you could send us a link to where people can access the wheels, that would be great.
Yeah.
Your sound is a bit coming and going, so maybe if you just finalize your
two final points. Sorry, now the Bernardo's library have incorporated a whole infant mental health literature access points. They've been working with us, and they have used our curriculum that we use here. So they have a whole area on their website as well. So we'll send you the information to that.
Great.
And there's great stuff on there. And just to say, the MBO training is happening this week. We have Kevin Nugent here with us virtually, and we hope to be able to bring the MBO training to more people over the coming years. And it was a real privilege to have him, I must say. So thank you. I'm sorry you can't.
Catherine, thanks so much for that, and we'll get those links together. And then finally, in this section, we're just going to go to Amy Fogarty in Preparing for Life. So, Amy, if you can just keep to that 4 minutes, please, or even less would be wonderful. So we're getting quite tight for time, but just give us a whistle-stop tour of your piece here. Not hearing your sound, Amy.
Apologies. I hope everyone can see my screen there.
Yeah.
I'm coming at it from a kind of a different angle this morning, because the resource that I'm about to show you guys is more so geared towards early childhood professionals and professionals who work with the 0 to 6 age range in general. So we've already heard people say this morning it takes a village to raise a child, and we've heard Julianne talk about how every interaction is an opportunity for an intervention. But holding both of those things in mind, I'm going to introduce you to the Growing Brain. The Growing Brain is an early childhood curriculum that's designed by 0 to 3. And it's basically a crash course in the neuroscience behind early childhood brain development, and how we can use that science to build healthy brains and foster really good, strong infant and early childhood mental health. So myself, I'm coming to you as a person who has done a level 5 QQI in childcare with special needs, a level 6 in childcare supervision, and then I went on to do my degree in early childhood education, and then went further on after that. But it was only when I started doing my degree in early childhood education that we even touched on any sort of relevance of how interaction and relationship can have the power to shape a child's brain. And when I was doing my degree, in my final year of the level 8, I was angry that it hadn't come to me any sooner than that, like proper angry. So what 0 to 3 have done here is they've designed a curriculum again that focuses on the neuroscience. We know that children in Ireland, there's more than a 95% participation rate within early childhood education schemes, particularly children who are 3 and 4. So if we arm early childhood practitioners with the knowledge around early brain development, that's a very powerful thing that we can do. It empowers early childhood professionals when so many of them are feeling so disempowered at the moment. So if my presentation would like to cooperate, and move on to the next slide, I'm preaching to the choir here. We all know who 0 to 3 are. This is a link to their website. They're a national not-for-profit organization in the US. They were founded in 1977 by some of the leading early childhood experts at the time. You can probably hear the yapping dogs down there. Apologies, they're not my yapping dogs. 0 to 3 focus on research, training, advocacy, and policy. And one of the things that they do is they have developed some wonderful train the trainer programs, one of which is the Growing Brain. So the Growing Brain focuses on 7 distinct units. It's a very experiential training curriculum. So it encourages participants to be up and down throughout the day, actually playing, actually doing some activities that would help them to experientially understand what the messages that the Growing Brain curriculum is trying to promote. The first unit is just the basics of the Growing Brain. It talks about transient exuberance and that kind of pruning process, that kind of more basic level of brain development that I think the video at the beginning by CDC that evidenced beautifully. It talks about practice making permanent when it comes to brain development, and it talks about using it to lose it. Those really basic messages when it comes to brain development. The second unit is a little bit more based on the stress continuum and the 5 R's of supporting healthy brain development, like relationships, responsive
Amy, I'm going to move you on quickly, as if we can, just to keep going, because we're running tight on time. So rather than go through each unit, we can send the links to people.
You've got unit 3, 4, 5, 6, and 7 then after that. And of course, the Growing Brain is open to the majority of us here today. The Growing Brain is 0 to 3 expect that people who are participating in their trainer of trainer programs have a good knowledge or expertise in child development and some experience as an adult trainer. So it's open to the majority of the people in this room. These are some examples of some of the content within the training manual. And it's funny because I had this quote as well. I can't remember who had it at the beginning. Was it Audrey? And I want you to just, for this sake of this quote, just translate the word from parent to early childhood practitioner, because it's the exact same sentiment. Every time we give early childhood practitioners a sense of success or empowerment, we're offering it to the baby indirectly as well.
Amy, thanks so much, and sorry for putting the pressure on there. Just in all of these things, we always run tight on time, and those would send those links on, and we'll send your presentation on. If you would send that over to Lindsay, that would be wonderful. Okay, so one of the key things which has happened around supporting the development of a really good quality practice in infant mental health has been the development of infant mental health networks, and we're going to take a peek inside the door of an infant mental health network in Clonmel now with Fionnuala and Naomi to talk to us about that. So over to you folks.
Thank you, Francis. I'm just waiting for Fionnuala to put the presentation up. I suppose just good morning to everybody, and it's a great pleasure for the Tipperary Infant Mental Health Network to be invited to present to you today. We're very proud of what we've achieved in Tipperary in the area of infant mental health, and therefore very happy to share our journey with you, more specifically on the experience of our reflective practice network. My name is Naomi Burke, and I'm the Centre Manager at the Clonmel Community Resource Centre. I've been involved in the project as a steering group member since the beginning of 2012, and have also facilitated the group with other IMH colleagues for a couple of years. And just to say that Clonmel Community Resource Centre's role is sort of to host the governance and the financial side of the project, sort of in relation to funders and things like that. So if we could move to slide 2, please, Fionnuala. And to put the network group into context, I need to share with you a little of how we came to be. It began with a conversation back in 2012 where the 3 psychologists, Fionnuala, Audrey and Rosari, came to myself and other colleagues in the community, and I remember it was community mothers and Bernardos. We were a small group of people, and the psychologist asked us, how could we bring infant mental health into the community for the benefit of the babies who we're all engaging with. I have to say for myself, I didn't know what infant mental health was then, so I had an awful lot to learn. but it was sold to us anyway. We were going to be part of it, whatever happened. The conversations multiplied, and we set up a steering group. We sought funding for masterclasses, and a wide range of professionals attended those masterclasses. And we learned that the only way to embed the learning into practice was for a reflective practice network to be established, where we'd regularly meet and study articles and share experiences. And I suppose the key message there is at the core of the reflective practice network is the baby, and the underpinning principle of infant mental health that all development occurs in the context of caregiving relationships. So if we could move to 3, yeah, thank you. We have a very rich and diverse group of skilled practitioners who are very committed to the reflective practice network.
Sorry, Naomi, you have frozen on us there. Fionnuala, I'm wondering, would it make sense for you to pick it up, and then we can re-engage with Naomi when her connection improves?
I'm just going to. Hi everybody. I'll just put it up again. We had, myself and Naomi had mentioned this, that if there was some problem with connection, we'd double up for each other. Which is a little bit hard because Naomi's next slide is about her own experience. Can you hear me?
We can hear you, yeah.
Okay. Maybe what I might do is, Naomi was just explaining who was attending in the group. We have a real mixture of, community providers. So Clonmel Community Resource Centre, we have a play therapist, the community mothers are well represented, and the Women's Refuge, Bernardo's. We also have people from TUSLA, social care leaders, and we have substance misuse counsellors, and we have early intervention, primary care, adult mental health, and community mental health, and PHN. So we have a real mixture of people at the group. The next slide was Naomi was going to share a lovely experience, I suppose, a story that she had of her experience in the group. I'm not going to speak for her.
Do you want to put the slides up, Fionnuala?
Can you see the slides?
No.
Oh, okay, sorry. No, all right, and they're very good. I'm looking at them. Just let me come out of this. Share screen. Share. Is that coming up now?
Hello?
Hello, Naomi.
Oh, I'm so sorry. I don't know what happened. I lost the internet.
Okay. Well, that's just.
So I think you've got the flavour of our network group. So I'm just going to finish my slide with a story about my experience going back about 5 or 6 years in the Reflective Practice Network group. So just to say that my job in the resource centre, I'm not working directly with parents and children all the time. I meet them, and it would be the universal approach. So I could be setting up projects, applying for funding, so a lot of different tasks. So there was me for the very first time about to present a case study after an article was researched, and I went into the group of professionals, and I felt quite vulnerable, I have to say. I felt that I probably didn't know as much as them. I had to share something that was difficult for me. I was stuck with a particular situation where a little boy's progress was stuck because of his relationship with his mother. And I didn't know how to progress. And I felt, as I say, I felt very vulnerable going into the group of people who may think, oh, you know, she doesn't know what she's doing, or what approach had I made? Had I done anything wrong? My confidence wasn't great. So I started to talk. The only way is to tell the story and encourage a conversation. So I told the group exactly what was going on and how I did feel vulnerable, and I was stuck, and I needed some help. And did anybody have any ideas? I was afraid that I might be judged. And gradually, I was very, very much aware that I was being heard, I was being listened to, and I was being supported. And the trust was beginning to be established. And greater conversation came out. I like the way you did this, but have you thought about maybe exploring that? And all the principles that we're learning as part of the infant mental health were coming out in the group helping me, which was just like supporting a mother. And it felt like the parallel process was working. And I started to feel confident. I started to know what I could introduce for the child. And I think really that's at the core of how a reflective practice network works. You build a relationship with the people that are at it. They're all coming from different places, and life experience and professional experience. And they're all people that I would have no problem picking the phone up and saying, what do you think about this? Can you help here? And I hope in turn that I have a perspective that is useful for them. And I just can't say enough how enriching it is, and how it does embed the theory into practice. It's been going 7 years, and I'd say maybe I've only missed half a dozen sessions in the time. So it's very, very special. And on that note, I'd like to pass on to Fionnuala. Thank you very much.
Thanks, Naomi. Well done for picking off when the worst happens, when your connection fails. So I suppose we were thinking about, Francis gave us some headings, and one of them was achievements, which is hard to describe in a long running kind of process, I suppose, as a group. But I think one of the biggest parts is that our practice has evolved and is evolving. We set up the network group at the start. Its function was to embed the learning that we were getting in the masterclass. So all those principles that Audrey mentioned at the start and that other people have mentioned this morning, we wanted those principles to be applied on an ongoing basis, and that it wouldn't be just something that's you revisit periodically. So we've asked our members in the group from time to time, in different ways, what do they get from the group? And these are some of the things that they've talked about in terms of their practice. A lot of people mentioned how they slow down, that they've noticed that their practice has been more at the family's pace, and that they are finding themselves working more to help families find their own solutions rather than imposing what they think the family need. And I suppose this helps to, it speaks to that principle of honouring the expertise of the parent. And it speaks to what Naomi spoke to there. We all need to help finding solutions, not being told what to do. We find that all the group are prioritising building relationships, which most people in this field do prioritise relationships, but that we now bring that awareness that the relationship is the way, it's our biggest tool, and it's the best way that we can help. So attending to our relationship with the parent,
and then helping the parent to attend to their relationship that's growing with their young child. Members are also kind of sharing that they're really trying to understand the baby's perspective now more, seeing things from the baby's perspective, alongside also having a real curiosity and awareness maybe about the parents' experiences, past and present, and how that might interfere with how they interact with us in a working capacity, and how it might interact with their developing relationship with their baby. And as Naomi mentioned, we've really grown together to understand each other's roles, and there's been a real forging of relationships within the group, and that helps really to foster that sense of an IMH community. Sorry, I pressed the wrong way. Each month we have different topics. We're following the Irish Association for Infant Mental Health competencies. They have a list of knowledge areas, and we follow those broadly. We have a different topic each month, and we do an article, but we also invite people to bring along a story or a case they're involved with. Unfortunately, I can't really share those stories with you today because the families that give their consent for their story to be shared in the group, it's just to be shared within that group. But I was just thinking it might be helpful just to hear a little bit about kind of typical processes or typical stories. We often hear first meetings. I'm sure lots of you have those experiences. The first meeting with a family, you hear stories of meeting maybe a family with a new baby, maybe a very overwhelmed or extremely stressed mother, father. We hear maybe how the worker experiences that, and that sense of being overwhelmed perhaps, or being flooded by the enormity of what's being thrown at you as you meet this family for the first time. And through hearing that, then we eventually get to what's it like for the baby? How does the baby experience this? And these types of stories kind of can often lead us to these types of discussions about how do we ask a parent about how they're feeling? Are they depressed? Are they anxious? And it kind of leads into the earlier talk. How do we talk about mental health? What stops us asking those questions? We've often found that we've had those discussions plenty of times, and we've talked about maybe we're overwhelmed ourselves, maybe we can't take it, maybe it's the last call of the day, or all those cultural things that we have in our own histories and in our own cultures that we come from about mental health. So the forum allows us to talk about those things. And other questions, maybe sometimes we get so taken up with the story of the parent or the housing situation or various dramas that are happening, that in the discussion the baby isn't mentioned. But there's always somebody in our group that will ask that question, like, what about the baby? Where is the baby? What's going on for the baby? And even that in itself is helpful for us to think, what stops us asking about the baby sometimes? Why sometimes is it hard for us to think about the baby's experience? And even that will lend us on to what makes it hard for a parent maybe to think about her baby's experience. So that leads back to all those ghosts in the nursery that we all have. We all have blind spots. So the whole focus of the group is really to help us have a space just for that to be uncovered a little bit. And we do it together in that we all experience, there's a kind of shared humanity in it. In terms of challenges, some of our challenges are that turning up each month can be a challenge, keeping that continuity. We're a closed group, and that feels that it's not just a drop in. The people that are in the group, and from time to time there are changes in new members. But we try to keep it predictable. It's trying to replicate, I suppose, that whole sense of with a parent and a baby about predictability. We have our routines, we have our little rituals, but we like to see the same people each month as well. We find also, I suppose, those that are facilitating, it can be a challenge to keep that time aside, because there's a bit of preparation in terms of facilitating. So that can be a challenge. We don't have all the people in our group that we would like. So there are most people that we talked about joining really do get it, but there are certain kind of groups of professionals maybe and workers that it's a real challenge for them to make a group like this. So maybe some of our social work TUSLA colleagues can find it very challenging. We don't have any medics or any pediatricians. As yet we don't have people working in early childcare. We have our community resource manager, Naomi and Catherine from the resource centre, but we don't have fresh workers as yet. So so there are some of those challenges. COVID is a challenge for us because we are meeting face to face, but we're trying to embrace technology and we're keeping linked in that way. Future plans, I suppose we hope to have growing our group, to have more groups in Tipperary. From January, we hope that there'll be some participants from the north of the county. We have a process in place that we're trying to pilot about rotating facilitators, so that 3 members of the group, we're mentoring them to provide that facilitation role for a year. And we hope that that will be rolled out, that another 3 will take it up another year. Our overall goal as a steering group, the wider steering group, is that everybody involved with children from 0 to 3 will have IMH knowledge and have that foundational basis. And we would love for everybody to be able to be part of a network group, because it really fosters that growing. And I suppose having opportunities like this to talk about the group is a real, it's something that we're happy to do as well. We've learned from other areas, and I think that's how we all learn together, and we get new ideas from each other. So reaching out is positive. Our key message really is that network groups are central to building an IMH community. We think they're really the bedrock of our. We had a goal years ago to build an IMH community, and that wasn't just about flyers or raising awareness talks and things like that. It actually is this, our network group is central to our IMH community. We have a group of people that can speak eloquently about infant mental health. They are using those principles all the time now. And they reach out in each of their own organizations. So there's so much has come out of the people that are in our existing group. They have branched out. They are raising awareness in every interaction that they make. And that's real, I suppose, would you call that? It's prevention in action. And it's building those relationships. But network groups, they need sustained support. We have learned that it takes a long, each year we grow and learn together even more. Remember, after the first year, we had such high expectations of ourselves, but looking back, we were only getting started. It does take a lot of investment of our time, but like the benefits are massive. I know that I have grown so much by being part of this group. I take great comfort as well about being part of a group like this. I presume most of you would, well, I would imagine many of us can find working in the area can be a bit isolating at times. We can all get overwhelmed by the needs of the families we meet, and they awaken in us our own babyhood. So it can be a hard area at times and rewarding area to work in. But it's having been part of a group can really sustain us when we're kind of losing the faith or wondering about it. The group can hold that hopefulness that Audrey mentioned as well. So and out of the group as well, it has helped been a launch pad for other initiatives, like in Tipperary we've brought Mellow Bumps and we brought the MBO, and that has kind of been a bedrock to bring those kind of initiatives, that the people are going to those trainings have a lived experience of infant mental health principles. So I have probably flown by, but I hope I'm in time. That's about it.
Fionnuala, that's wonderful, and thanks to you and Naomi. I mean, one of the things I'm getting is a real sense of, first of all, for parents, what the values are of infant mental health, and there's just the support network and the respect that's there, and how that set of values and that atmosphere then translates into practitioners as well, and into how practitioners work together. So we're moving now into the closing session, which is panel discussion. And if people want to raise any questions for our panel members, for the speakers throughout the session, please just put, if you could either put your hand up. I'm not sure how my hand up process is working here, or else just put a message in the chat box. And I'm going to kick off by asking Fionnuala, if I'm attending this webinar and I want to find out, is there an infant mental health network in my area? How do I find that out? And if there isn't, and I want to get some help and support in setting one up, how would I go about that?
That's a really good question. I think I would go first of all to the Irish Association for Infant Mental Health. They are a good central organising centre for what's going on in the country, and they would have a good handle on what network groups are available in the country. Are you getting a funny sound from me? Yeah.
Yeah, I would recommend unplugging and plugging them back in, maybe. Go again, sorry.
Yeah, okay. That's all right?
Yeah, that's a bit better. You're just a bit low, so maybe just make sure you're speaking into the microphone.
Okay,
but
sorry.
yeah, perfect.
So I think, Francis, going to the Irish Association would be a good place to start, and they'll have links. That has happened in the past, and I think we in Tipperary be very helpful or willing to link in with anybody who's wanting to start a network in their area. We've learned a lot over the years about what's needed, and we're very willing to help and to reach out to anybody.
That's great, and I know Catherine Harford in Cork was mentioning to me that they
Yes.
have a network of networks there, so that a group of different networks are linking together to do work together as well. So it's just a case of how to find your way into that. I'm gonna fire a question off to Julianne now, and I'm going to ask you, if I am a pregnant woman living in your catchment area, how will I experience the values of infant mental health through my pregnancy and through my parenting journey? How's that going to impact on my life? How am I going to get the inputs?
Well, hopefully, if we get an early referral, for example, the public health team in Young Ballymun will have contact with the families, and also obviously the maternity hospitals will. And we're hoping in Young Ballymun to get early referrals to the infant mental health home visiting team at that point, so that we can build relationships with the mothers at the point where they're carrying their babies before they actually have their babies. And so what they'll experience is some space to wonder about the future with their babies, to wonder about what's going on inside of them, to kind of, we say, mentalize about what type of baby they'll have, and what from their own past experiences might make it might influence how they receive their baby when they arrive. So just a space to give the parent a time to think about what they'd like for their baby in the future, and what their fears are, what their hopes are, all of that, so that already the baby starts to become a real entity for the parent.
That's great, Julianne. Thanks for that. Can I link back to Audrey now and just ask Audrey maybe to say a little bit about training that again, if there are people here today who say, God, I'd love to find out more about that, what's the range of training that might be available? I'm aware that some of the work the HSE are doing under the Nurture program is developing a number of modules on infant mental health for use at a universal level, and then the range of training that might be accessible in the future through the Irish Association.
Yeah, so in normal times, we, if people email into that link that I gave on my slides there and contact the training officer, we normally run a series of masterclasses that really are, I suppose, are designed for people that want to start a network group. So the masterclass would normally run for 2 days, and at the end of the 2 days, there's time to think about what setting up a network group might look like and some ideas around how to proceed from there. So that's one aspect. And then there's introductory training as well, which is geared to, I suppose, that raising awareness if people haven't prior knowledge of infant mental health. I think one of the upsides of COVID has been the fact that a lot of training is going online now. Now, we haven't been, I think, because the masterclass is so reflective, and it would be very hard, I think, to do that online. But look, you never know. And then there's the online trainings from Warwick University. That would be the association in the UK.
Right.
They have some really good trainings in that, yeah. So does that kind of answer your query, Francis?
That's great. That's really helpful. Anybody want to pick
can
up?
Can I just say the chat function I'm not able to do. I don't know as anybody else.
Okay.
No, Julianne, that's why I was just coming in.
Okay, so that sounds like, who does that sound like?
It's Bernie and Julianne,
Bernie,
I think.
have you something you wanted to?
It's probably a comment rather than a question, and I suppose Fionnuala talked about infant mental health knowledge being a foundation for everybody that works with the 0 to 3s, and I suppose we'd argue probably even beyond that. But I suppose it's the aspiration around how can we get to the point where everybody in that workforce can actually be part of an infant mental health network. And obviously the ABCs, through kind of the mentoring with Young Knocknaheeny and Young Ballymun, are a good bit down the journey of having infant mental health networks throughout most of the ABC sites. But ABC is only in 12 areas. We know that HSE and Clonmel and others have the infant mental health network. It just seems there's still such a huge amount of work to happen to kind of raise that capacity throughout the whole of the workforce that's working with that group. And I know in ABC, we've been in touch with the Irish Association and in linking in with Nurture as well. But I think there's probably that need beyond those networks as well around how can we really build this capacity. So it's more a comment. I know it's a challenge and it's a question there.
Could I put a question to the group? Can I ask, what is the scope for early years professionals within the field of infant mental health? And by that, I mean, I'm also trained as a filial therapist before I went. At the moment, I'm doing a PhD in infant mental health with Trinity College. I'm doing it in social and emotional development and coming at it from a brain development perspective. So it would be the mechanisms. What I'm studying at the moment are the mechanisms of why infant mental health is so important. So it's not just saying, yes, it's important. I'm actually studying the neural networks that would show us why it's important. So I'm wondering, I'm also an early years practitioner. Well, I was in a previous life an early years practitioner for many, many years. Can I ask what the scope for practice within early years would be? Because they're not, we've got to be fair. I would understand a practitioner feeling out of their depth because a lot of the talk around infant mental health can be psychological functioning, and they can use a lot of psychological and psychology words that can disenfranchise early years practitioners. I don't want them to feel that they are in above their heads or that they're in among professionals who make them feel like they don't know what they're talking about. I want them to understand that this is part of their remit just as much as it is part of a psychologist's remit or a psychiatrist's remit. I want them to feel part of it. But at the same time, where do we draw the line between psychiatry and infant mental health for ECI, for early years staff? Does that make sense?
It makes sense. It's a big question. So anybody like to step up to the mark on that one?
Could I give an example from Young Ballymun?
Please, yeah. And
right.
I just can't hear you very well.
Can everybody hear me? Can you hear me?
Yeah, I can hear. I can, yeah.
Yeah, keep going.
We have offered infant mental health masterclasses to practitioners in the area, and then we found that early years practitioners can't come to the network because it happens in the middle of the day, and there's difficulty with people getting off and getting room coverage. So we offer infant mental health reflective supervision on a monthly basis to 2 of the TUSLA services in our area. So that's how we're supporting the practitioners to have an infant mental health lens in the work that they're doing, and then to embed what they have learned in the masterclass, because you can attend a masterclass, but that just whets your appetite. It's the learning in like how you do infant mental health, and all about how your relationship with the child and with the parents, how they all influence each other. So that's how we've managed in Ballymun. And we've also quite a few practitioners trained in the Circle of Security Parenting Programme, so that they're using that in the room with the children, because they are attachment figures for the children, but they also then support the parents by delivering that to parents who attend the service. So they're supporting parents, and the children are getting the same message and the same approach from the practitioners in the room, and then from the parents at home. So that's how we've kind of supported that in Ballymun.
Thanks for that, Hazel. I was just about to make a point, and I see that Catherine has made it already for me in the chat. And that's infant mental health needs to be embedded in the core professional training of everybody who is going to be working with children and families throughout their career. So it's about getting it in there. And then there's only, I think, probably a certain population of professionals who will be using it to such a deep extent in their work that they're going to be attending networks. The networks are never going to have everybody as part of it, but I think it's how it becomes part of the core training as opposed to an add-on in the training of the overall workforce, and then how it can be supported for more specialist development. And it's about that continuum, I think, from using it in a very, very specialized way into using it absolutely universal. Maybe Sorka has been talking to us about earlier on. Okay, any final questions or comments? If not, we're going to move over. We're kind of running beyond time at this stage, so apologies for that. I think what we're going to do at this stage is I'm going to ask Rebecca to put up our final Mentimeter question. And this is just words that summarize your experience of the webinar to get a little bit of feedback now. This does not absolve you from doing your online evaluation form. What's really important about the online evaluation form is if you can tell us what you want now from PEIN in terms of training and experience. So both, is there a follow-on from this topic on infant mental health that you'd like us to pick up on next year? And are there totally different topics that you'd like us to pick up on? But just if there are particular, how you would summarize how this webinar has been for you. One of my learnings is I always try to fit in too much to a webinar, and we've felt pressurized for time, and maybe I just probably need to try to get 2/3 of what I want to get in. So powerful and interesting is a nice way to start the ball rolling. Okay, enjoyable. Clonmel project is inspiring. They're doing great work down there. Love the case studies. Yeah. Collaborative. Really engaging. Okay, informative, sharing, interesting, inspirational. Okay. So as you continue to do that, I'm just going to make a couple of thank yous. I'm going to thank everybody who spoke. at the event and everybody who inputted to it. I'm going to thank everybody who's attended it. I want to give a particular thanks to three people. I want to give a particular thanks to Julianne Lyons, who's left us, that when this idea came up, I asked Julianne, would she work with me on developing the content and the structure for the webinar. So thanks to Julianne on that. And a huge thank you to our technical support provided by Rebecca. And Rebecca, I know you're moving on from CDI shortly, so good luck on your future journey, and I hope you keep contact with PEIN in the future, and whoever gets to work with them in the future will be a very lucky organization. And then a major thank you to Lindsay for the organization of everything to make this happen. I am totally technically inept, and without people like Rebecca and Lindsay around me, nothing would happen. So thank you very much for them for doing that. So again, just take a look there. There's a lot, keeping the baby in mind. I think that putting the baby at the center of our thoughts so much, you can be overwhelmed as a professional for all the different issues that are going on in the family, and you can forget to find out where the baby is. I did have one question to think about, which is, I don't think we've mentioned fathers today. So, you know, infant mental health and fathers' role in supporting infant mental health would be an important one. Infant mental health training in the ECHI workforce completely aligned with Ashton and Shilta is an important comment there, just coming in from Catherine as well. Okay, with that, I'm going to thank everybody, wish everybody a happy Christmas, and give everybody the best wishes for somebody's cat has just crossed the table there, Hazel. Give everybody the very best wishes for a safe and secure 2021. So take care, everybody, and thanks a lot.
Thanks, Francis.
Thanks very much.
Bye-bye.
Thank you. Bye-bye.
Bye. Thank you. Bye-bye.
Well done, everybody. Thanks.